Hello, and welcome to the Dr. Rebecca Baxt podcast. I'm Dr. Rebecca Baxt, board-certified dermatologist, and I'm here to discuss with you all issues relating to the skin that you're in. In this podcast, we will tackle the topic of the day quickly to get you the take-home points that you need. After listening to an episode, you should be educated about the topic and able to fix the issue yourself or well prepared to ask the right questions at your next dermatology appointment. Let's get started. Hello, listeners. Today we are going to talk about a hot topic, no pun intended, menopause. I've been working on this podcast for a while, had to get all my thoughts together because menopause is a very large topic and it's complicated. But it's a really important topic. It affects all women at some point. On average, most women go through menopause between 45 and 55. But some reach it earlier and some reach it later, but all of us suffer from the consequences of the loss of estrogen. So today I would like to discuss menopause from a dermatology perspective. What do I see in my office as issues that women complain about as they reach perimenopause and menopause, and what can we do about it? Our agenda today is going to be covering first perimenopausal and menopausal breakouts. Second, we're going to talk about hair loss. Third, we are going to talk about dry and brittle skin, hair, and nails. And fourth, we are going to talk about cosmetic issues. I'm going to tackle these complicated issues one by one, discuss them and how we treat them. And some of them have other podcasts that are related, and those will be in the show notes if you would like to listen to those as well. So first, let's talk about breakouts. It is sadly very common for women in their 40s and 50s to develop acne or rosacea, and this is thought to be due to hormonal changes and hormonal imbalance. And I wish I could tell you that taking hormone replacement therapy fixed this issue, but I have not seen that to be true in practice. So we are basically left with acne and rosacea, often new onset for women at this age, and sometimes it's a recurrence of acne or rosacea that they had when they were younger that now comes out when they're going through perimenopause. So it could be new, it could be a resurgence, but whatever it is always very bothersome because it makes people feel like they are teenage children with bad breakouts and they can't control it, and it's very upsetting. This is a serious issue. We take it very seriously, and it is fixable, just requires time, effort, and work. The first thing I like to do is get patients on a really good skincare program. So a mild cleanser is really helpful that is not too irritating or drying, since a lot of the creams that we're going to use for these conditions can be drying. I like patients to make sure that their moisturizers, sunscreens, and makeup are all oil-free so that they do not clog their pores. So once they have a mild cleanser and they are using oil-free products, then we can start to use some things with active ingredients. I love azelaic acid prescription gel for these conditions since it kills bacteria and unclogs pores, and it's usually pretty tolerable. It comes in a gel and a foam, and I will often prescribe that. For people who cannot tolerate azelaic acid, or sometimes in addition to the azelaic acid, I will often use clindamycin lotion or Metro lotion or a different topical antibiotic lotion of some type. Then we'd like to get patients on retinoids if they can tolerate it, such as Retin-A, retinol, Differin. They are very useful because they help unclog the pores. They're also good for anti-wrinkle. They help fade pigment, but they're very good for helping prevent breakouts, and people have to start them pretty slowly. If people have oily skin, they can usually also add on more typical anti-acne program ingredients such as benzoyl peroxide and salicylic acid, but a lot of patients who are going through this, their skin is dry and they cannot tolerate those chemicals. So this is really very patient dependent, and a skincare program has to be set up for each patient with their particular skin, their issues, and their lifestyle. Getting this acne or rosacea breakout situation under control often means stopping the many serums and toners and anti-aging things that people are using and refocusing on anti-acne and anti-rosacea programs. This is really not the time for TikTok skin care trends or buying something from the drugstore that you think might work or borrowing something from a friend. This is really a medical issue. It often requires the advice of a board-certified dermatologist. And good news, these conditions are very treatable. If patients are concerned about anti-aging, which many are, I always remind them that retinoids are the best anti-aging cream on the market other than sunblock, and that is true. So once we can get the skin care under control, then we are in good shape. And so if all these topical creams are working well and the patient is on a good cleanser and a good sunblock and good skin care and they're doing well, great. But it's often not enough because sometimes people at this age are developing cystic acne or cystic rosacea and the creams don't do the trick. So then we need pills such as oral antibiotics, oral spironolactone, and occasionally even Accutane or isotretinoin, sometimes birth control pills, and I will often coordinate care with the patient's gynecologist. There are also many patients who do not want to take pills or cannot take pills, and we have many other treatments to offer that work. I love the Smooth Beam laser for acne for this. It's an old but very effective laser that works incredibly well. Also, chemical peels can be very useful if patients can tolerate them to help exfoliate and reduce breakouts. We also have photodynamic therapy. There are lots of things that we can do to help reduce the breakouts that do not require pills. We also offer steroid injections for the cysts if the patient can get into the office. And this, as you can imagine, is a very complicated issue, and we definitely have 2 other podcasts, one on acne and one on rosacea, and those will be in the show notes if you're looking for more information. They're back in season 1. So I'd like to move on to the second most common complaint that I see from patients in menopause or perimenopause, and that is hair loss. And this can be truly devastating. The type of hair loss that is associated with menopause is called androgenetic alopecia, or what we commonly call female pattern hair thinning. Women tend to get thin on the top and the sides of the head, but not in the back. It's a different presentation than men. And there can be episodes of increased shedding as the hormones shift and we lose estrogen, and it usually happens fairly slowly. The top just starts to be thinner. Women who used to have really thick hair find their ponytails are half the size, and it's very, very upsetting. The diagnosis is usually fairly easy for me to make, that they have androgenetic alopecia, but I always want to rule out other causes of hair loss, which are also possible. And so if I'm not clear on the cause of the hair loss with the history and the physical exam, I will recommend a scalp biopsy where we take a tiny piece of the skin on the scalp and send it to the lab to get more information as to what is causing the hair loss. But assuming we are dealing with the usual female pattern thinning, we dive into what to do about it. If it's a mild case, I will often recommend topical over-the-counter Rogaine, 5%. It comes in a liquid or a foam. People can use it once or twice a day. The men's and the women's are basically the same thing, just with different packaging. The foam is less irritating. We also have a 7% variety in our office, which works well. But I will say that on the whole, it gives maybe 20% improvement. And it's annoying to use because you have to put it in every day. Not everybody washes their hair every day. A lot of people don't like how it leaves their hair and their scalp. It can cause irritation, as I mentioned. So if they cannot tolerate this topical treatment, or they have a more severe case, we can absolutely go to Rogaine pills. So Rogaine pills, the generic name is minoxidil, and these are usually pretty well tolerated. Oral minoxidil is a blood pressure medication that we use for stimulating hair growth, and we start it low and titrate it up. The main side effect is that it can cause hair growth elsewhere on the body. Most women are so happy with what it does for their head that they are willing to remove other hair on their body with other methods, either laser or shaving or waxing, whatever it takes, so that the hair on their heads will grow better. But it also is a blood pressure medication, so it can cause palpitations and lightheadedness and swelling in the body. So we usually start it low. Most people tolerate it, and it works incredibly well. That is my favorite pill for this, but there are other pills that we can use, such as spironolactone can often help. In addition, after we've dealt with the topicals and pills, I will often recommend low-level laser therapy, otherwise known as LLLT, which patients can buy on their own online. It comes in either a cap or a band or a comb. The comb is good for small areas, so if people just have the sides of their head that is getting a little bit thin, the comb would work well. If it's the whole front, I often recommend the band. The cap, I find, is not as useful for women because I don't think that the light penetrates well when you stick it on the top of your head unless the hair loss is very advanced, in which case the cap is easy and useful. So people will use it a couple of times a week, and again, maybe it will give a 10% improvement, but it is harmless. It just requires a little time, and it does cost money online to buy the devices. But once we have a primary treatment plan that usually involves either topical or oral Rogaine and using a laser of some type, we can always add PRP. PRP is platelet-rich plasma therapy. That's when we draw a big tube of blood out of the arm, we spin it down, we remove the red cells and the white cells, and we concentrate the plasma, resuspend the platelets, and inject it into the scalp. I tell patients that there are 3 downsides to it. It's really considered experimental, it's a little expensive, and it hurts. But I find that it works especially well for women with hormonal hair loss, and so we do it pretty frequently in the office. The protocol that we follow is once a month for 4 to 5 months, and then every 3 to 6 months for maintenance. Patients tolerate it pretty well. I ask them to come in well-fed and well-hydrated, and it's a good adjunctive therapy in addition to the primary treatments. The PRP just helps stimulate the hair to grow thicker and better with all the growth factors that come from the platelets. There are certain cases where women are eligible for hair transplantation surgery. That is not something that I do, but I will refer out for that if it's needed. It's not typically needed, but if it is, then that's a great permanent solution. And if you're looking to learn more about hair loss, there is a longer podcast just on hair loss, and that will be in the show notes. Now I'd like to move on to the dryness of the skin, the hair, and the nails. I'm not going to get into much detail on vaginal dryness as I'm a dermatologist and I defer the management of that to the OBGYNs. But quick advice on vaginal dryness is to discuss hormone replacement therapy or vaginal estrogen with the OBGYN. And for those looking for non-hormonal therapy, to find a good cream or insert moisturizer that works well, there are many available on the market. Now I am going to focus on the skin, hair, and nails, which is really what I do. And they all get drier as we lose estrogen. So it's relatively easy to help reduce the dryness by using more moisturizer and reducing washing and soap. So for the face, I would recommend oil-free moisturizer if the patient is prone to breakouts, but if they're not breaking out from anything, then thick moisturizers are fine. I'm really not particularly wedded to any one brand. Whatever brand works for the patient is fine with me. We have our own brand in the office. There are plenty of good over-the-counter brands. It does not need to be really expensive. And this goes the same for the body. Vanicream is a hypoallergenic brand that I like, but again, whatever works is good. And thicker moisturizers, if needed, could be Vaseline, petroleum jelly, Aquaphor, coconut oil, or something similar, really whatever works for the patient. It's important not to scrub the body in the shower because hot water and soap is definitely going to make dryness worse. So I like to remind people just to use soap where it's needed, such as the hands, the feet, under the arms, and the groin. And also, laying off the manicures and giving the nails time to breathe and layering on a thick moisturizer for the hands and the nails is helpful. For the nails, I usually recommend Elon or Cutamol, but Vaseline or Aquaphor is also good. I also recommend keeping the nails short if they are brittle and getting more ridgy, and moisturizing many times a day for the hands. The face twice a day is usually enough. The body once or twice a day is usually enough, but the hands need many times a day because we wash them many times a day. So to reduce the dryness, it's really about reducing washing as best as you can and then increasing the moisturizer. I'd also like to touch upon the hair getting dry and brittle. And this really requires us to cut back on the washing, so less shampoo, and increasing the moisturizer on the hair, which is more conditioner. If regular conditioner is not enough, then some people like coconut oil, mask treatments, or asking your hairdresser for a product for deep conditioning. And that usually solves the issue with the hair. So I'd like to move on to talking about cosmetic issues, especially on the face and neck, but I will also mention the body skin before I dive into the face and neck. So on the body, as women reach menopause, they often complain about crepey skin, especially on the arms. And this is a very tough problem without a lot of great solutions. But I would say that sunblock and sun avoidance are really important because the sun just degrades the collagen, and menopause also reduces collagen and elastin in the skin, so the sun just adds fuel to the fire. So the first defense is no sun on any skin if possible, which means good sunblock and clothing, etc. The crepiness can be made moderately better by moisturizing effectively. Sometimes I will recommend particular moisturizers such as a glycolic body lotion, we have that in our office, or something similar, but crepey skin is really hard to treat. We also offer Elecor and Ulthera skin tightening treatments, which are off-label for use on the body, but they can be helpful, and if you are interested in hearing more about those, please listen to those podcasts in Season 1 and Season 2, Elecor in Season 1, Ultherapy in Season 2, and we will put them in the show notes. Moving on to the face and neck, which is probably one of the most common complaints that I get, is that people's skin is dull, and they are bothered by wrinkles and new hollowness in the face, and they are really bothered by their jawlines and their neck, which can be saggy and wrinkly and show loose skin. These are all tough problems, but they can be treated, so let's tackle them one at a time. For dull skin, a skincare program is essential, with mild cleansers, good moisturizers, great sunblocks, and then retinoids if possible, such as Retin-A or retinol, glycolic acid, vitamin C, and peptides, and using these in combination can really help the skin to look brighter and healthier. We will put a link in the show notes to my podcast on anti-aging skincare, which will go over all that in more detail. There are also treatments for the skin, such as laser resurfacing like Fraxel or Clear and Brilliant, as well as light treatments such as intense pulse light photofacials or chemical peels that can help. And when a patient comes in, we have a discussion and we make a treatment plan that works for their lifestyle and budget. There are ways to help all patients, and if you want to hear more about the laser resurfacing, the photofacials, skin tightening procedures, again, all of those podcasts will be in the show notes. Let's talk about the wrinkles on the face in particular. These are different for each and every patient, but generally speaking, the wrinkles that are from motion, such as the 11s between the eyebrows, the forehead wrinkles, and the crow's feet, can be effectively treated with Botox. While it is true that Botox can be preventative if started early enough, starting in your 40s, 50s, or 60s is completely fine. It can turn back the clock significantly by reducing the wrinkles, even if they are not totally gone. So Botox is absolutely still worth doing and starting in the menopausal years. There are other more static or stationary wrinkles on the face that we often treat with fillers, such as Juvederm or Restylane or RHA. Those fillers are made of hyaluronic acid, and they are often used on the lower face, and Botox is often for the upper face, but we can move them around as needed for a particular patient. For example, fillers in the temples can do a lot to make somebody look younger, and Botox around the mouth and chin can also reduce lines and wrinkles in those areas. So the treatment plan is really individualized depending on what the patient needs. It is common as we reach menopause to have the mid-cheek fat pad start to disappear and descend, and women get hollowed out looking and start to develop nasolabial folds, lines around the chin and corners of the mouth, and also the dreaded jowls or pre-jowls. A lot of this can be remedied with fillers, but I am honest with my patients, and if they need or want plastic surgery, then they can do that. There are also skin tightening procedures that in particular can help with the jowls and the pre-jowls, such as Elecor and Ultherapy. And I find that most of my patients entering perimenopause or menopause do not really need plastic surgery. They mostly need an aggressive supportive program that helps them keep looking just like themselves, not somebody else, and natural, graceful aging. The point is not to look like you were 20. We try to aim for 5 to 10 years younger than the actual age of the patient. This is almost always achievable if the patient is willing to do the work. And if you are interested in learning more about Botox and fillers or the skin tightening devices, please listen to those podcasts. They'll be listed in the show notes. Lastly, I want to discuss the neck. Wow, women are really bothered by their necks. The neck is often ignored earlier in life and gets a lot of sun damage, which is not helpful. So the first line of defense is sunblock and sun avoidance with big hats, sunscreen, and staying in the shade. But besides for sunblock, when the neck skin starts to age and get crepey, I recommend retinoids such as retinol at night and a peptide cream in the morning, such as the neotherapy. And we have these things in our office, but you can also buy them elsewhere. Sometimes I will recommend either Fraxel or Clear and Brilliant laser or photofacials, depending on what the patients need to help rejuvenate the skin of the neck. And then again, we also offer skin tightening procedures. I truly love Ulthera for the jawline and the neck. We have a lot of success with it, especially tightening up the jawline and under the chin and reducing the excess skin in that area. Ellacor also works well. I would also like to mention that Botox works great for the vertical neck bands and is now FDA approved for that. And there are some fillers that I will use in the neck, such as Bellatero or Skinvive, for horizontal necklines and crepey skin. So there are lots of effective treatments to help the neck. So in summary, perimenopause and menopause hit all women at different points in their lives. There are lots of changes that happen to the skin, hair, and nails. It is all treatable. So if you or anyone you know are suffering with dull skin, loss of volume on the face, wrinkles, hair loss, dry and brittle hair and nails, or breakouts, please see a board-certified dermatologist to get help. Thanks for listening. I hope that was helpful. Thank you so much for joining me today on the Dr. Rebecca Baxt podcast. I'm Dr. Rebecca Baxt, board-certified dermatologist. I hope this episode was informative and that you enjoyed listening. If you found this podcast useful, please give us a 5-star rating wherever you get your podcasts. It helps others find us so we can help them too. Just a caveat to remember, this is not medical advice, and please see your dermatologist or doctor for questions pertaining to your specific situation. I look forward to talking with you again in the next episode.